Hi. Uh, this tape's aimed toward the significant others of recovering persons because there's a lot of misconceptions in the field, a lot of strong feelings one way or the other, and in the end the recovering person is damaged and injured by the misconceptions and the fallacies and the support, not getting the support that they really need and deserve. So I'm going to start by eliminating some of the bad ideas that are circulating and help you get on track with the loved one that is there that you want to help. All right, so where do we start? First idea is SUBOXONE itself. SUBOXONE is an opiate, so people think of it right away as like a drug, a bad drug, and somebody who's on SUBOXONE is just on another opiate and they're no better off. So there has to be a line drawn in the sand between what is useful, working, helpful, and moving a person into recovery and what is not. Well, street opiate is not moving them in anything helpful. But SUBOXONE has a unique property, and it is the insulin, as insulin is to diabetes. It works very well for recovering people and is necessary for the support person to get out of their mind that they're just taking another drug and just making up excuses, because that's what comes to mind. The SUBOXONE has in it an opiate which is called Buprenorphine, and it also has an opiate blocker which is called naloxone. And what happens is they take the opiate, they don't have the withdrawal experience, they don't have cravings now, and they feel productive and energetic and not depressed. Now, if they want to feel a little bit better and take a little bit of opiate on the side that they shouldn't be, the naloxone that's in the same pill will block the additional opiate. So only so much opiates can get into the body when you're taking SUBOXONE. So somebody who's misusing it, taking it for the wrong purposes, can take all the heroin they want on top of it. It's not going to do anything for them, because the naloxone won't allow it. It will allow enough basic buprenorphine to get in there and work and do its job, but it won't allow the abuse situation to take place. So it's a cast on a broken leg, basically, and we're in there to fix what's broken and let the brain recover itself, and talk about getting off the SUBOXONE when things are all fixed inside. It's like refurbishing a house. You got to do the kitchen, and you got to do the basement, and you have to do the attic, but you don't want to fire all the renovators before the house is done, because you're just back in chaos again. So the job is to get life working, moving forward, repair of the self-esteem, basically. And if SUBOXONE does that job, then that's the name of the game. All right, what else? We also prescribe for most people benzodiazepines. That's Valium, Klonopin, and Ativan usually. We don't prescribe Xanax because it's got a street value, and people will come in asking for Xanax and will then wind up selling it, and we don't want to have these people brought into the practice. But unfortunately, if we're giving Klonopin like we do to most, people are thinking right away that's Xanax and it's being abused and misused. Now, sometimes it is, that's the facts. But the Klonopin is also another medication to help mainly with anxiety. It's not known that most people who commit suicide are not committing suicide because they're depressed, feel worthless and helpless, their lives are over. Most suicides are committed because people are anxious and they can't handle it, and they decide it's the only way I can get out. So the anxiety is a very crippling problem, and the Klonopin is something that works well for the anxiety. So Klonopin's got a bad name, and SUBOXONE has a bad name, but we've got to get past the name into the reality of what we're trying to do here. Thanks for listening.